Good morning, good evening, good afternoon to all of our friends globally who are joining us again one more time for our global partner. My name is Dr. Emily Letran. I'm a practicing dentist in Southern California and a member of the Global Institute. And it is my honor this morning, early morning from California, to interview Dr. Duc-Minh Lam-Do. He has received his DMD in dentistry at the University of Montreal in 2004. He completed a postgrad certificate in multidisciplinary dentistry from the University of Rochester, New York in 2005. He has continued his training in aesthetic and occlusal rehabilitation, treatment of tongue and lip ties, and treatment of sleep apnea and implantology. For the past 16 years, he has been emphasizing in his practice on functional and physiological dentistry. He is the co-founder of teledentist.com, the first teledentistry platform in Quebec. He's the founder of the Montreal Tongue-Tie Institute, a comprehensive multidisciplinary center for the treatment of ankyloglossia for babies, children, and adults who have issues related with breathing, swallowing, breastfeeding, speech, and craniofacial growth. Dr. Lam, though, is one of the 6 dentists in Quebec who has a mastership from the American Academy of Dental Sleep Medicine. He's a fellow of the Academy of General Dentistry, a fellow of the International Congress of Oral Implantologists, and an accredited laser provider from the Academy of Laser Dentistry. Dr. Duc, good morning and welcome to our partner.
Good morning, Dr. Letran. Thank you for welcoming me, and early morning for you. Not so much for me. Here in
Right.
Quebec, now it's a little bit past 10 a.m.
10 o'clock, right?
I had time to do my morning run and my workout. It's a beautiful day here in Montreal. Little bit chilly, but at least we have a nice sun, as you can see in my background. So it's a nice one. Take advantage of that.
Yeah, well, it's awesome to welcome you to the partner, because what we want to do is we want to bring values and we want to share our expertise to all of our colleagues across the globe. And so I wanted to ask you a couple of questions before you start your presentation.
Sure.
Why did you choose to focus on tongue tie and laser dentistry? Was there a personal experience that brought you to this?
So it's a great question, right? It's people, I'm a general dentist, and people are always sometimes surprised when they come to the office and they see a couple babies there. They're wondering what's happening, what's going on. And of course, there was a first patient number 1, who came in a little bit over 10 years ago. And the mom was a patient of ours at the office. And so she came in with her baby, expecting me to do the tongue tie surgery, because at the hospital where she gave birth, the physician told her to get a referral to the dentist, and go back to her dentist and have the procedure done, because they didn't do it at that moment at that particular hospital. So she came in, and trust me, I was as surprised as some patients when I had that 3-year-old baby sitting on my chair with her mom, figuring what's going on. Luckily, I have a pediatric dentist friend, so I gave her a call, and she kind of walked me through a little bit of that procedure. But mostly what I took out of that was the immediate change that happened right at that moment, after the surgery, where baby was able to feed for the first time adequately, to get a good latch for the first time since baby was born 3 days ago. And you could just see, mom's eyes just light up, from that, kind of rejoice and maybe reconnected with the joy of being able to breastfeed for the first time.
So you see babies as young as a couple of days? Is that what you're saying?
As a couple of days, yeah. I mean, the procedure sometimes it's done even at the hospital before you guys are discharged, even. So it just depends on the hospital. Some offer it not a lot offer it, unfortunately, but it is sometimes done even, that early. My office is really next to one of the hospital in the neighborhood where I live, and I have some parents sometimes just they leave and then they just walk to our office and get the procedure done. But we'll talk about it, and it's something that is done really at any age for different reasons. But I think for today's presentation we'll focus mostly on the babies clientele.
Right.
But we can definitely talk hours and hours and about this topic of tongue and lip ties.
So you are attending at the hospitals also?
No, so
as part of this?
Actually at the hospital, so it's a family practice. I work there with my wife. My wife's the other dentist at the office, and she was working. She was one of the dentists on call at the hospital in our neighborhood.
Okay.
And so we get contacts in that aspect. But so my residency was done in the hospital. So in 2004, I did a residency in Rochester. Did not get the opportunity to witness this procedure, even though it was it was a general practice residency with a little bit more focus and emphasis on surgery. But we did not cover this topic at that moment.
So you have you and your wife are both practicing in the same office. How long has it been that you're practicing together and you haven't killed each other off?
Oh my God, yeah. So we've been at the office for it's gonna be 13 years now. I'm a little bit more present at that office since the last 3 years. So I graduated 2004. She graduated in 2006. And so during the first years of our career, we practiced at different places. And
as
I guess we at different, as associate. Yeah. Well, she opened her office as well. So this office is 13 years old. And then I guess we miss each other so much that we had to rejuvenate and join forces. And so since 3 years ago, I'm much more present at the current office where I'm at. It's about 3 days a week, but it's rare that we're at the office the same days. So I guess that's the secret.
So between you two, you have 3 practices. Is that what it is?
2 now. Yeah. So at this point, it's 2.
So
one practice 3 years ago, one practice I decided to move. It was at a point in our career. So we have a young daughter, and she just turned 7 recently. So family time was kind of lacking, and putting all the cards on the table, 3 offices was too much. And so one had to kind of merge with the other. That was a strategy. And so it was either my wife, she came to me at my office, or I came to her. As you know, with women, she won the argument. So I came to her. Of course,
because we're always right. So we got
That's right. That's right. That's right. Even when you're not, I'm making sure to tell you that you're right.
Exactly. Well, it's really great. I mean, I'm not into pediatric dentistry or as in the field of pediatrician, but I know a lot of time we see more women, or maybe that's just my understanding. Or a lot of my friends, like when you go into pedo and you deal with little kids, tend to be a lady, and so it's great to see a doctor like you focusing on that particular niche, we can call that. And would you say that this is a very we'll say profitable? Is this a procedure where you can make a living? I know it's not like implant surgery, but how would you look at this? And if somebody asks you, why do you focus on this? What's your answer?
Yeah. So like I said, I'm a general dentist, and there's different procedures that I do. I really love everything about dentistry. Maybe orthodontics. I'll let my wife focus more on that, and that's, I guess, how we complement each other so well. It is a profitable procedure. That's for sure. But there's a lot that entails with doing this type of thing. You have to do follow-ups, and it is time consuming outside of the office as well, writing reports to other healthcare professionals who referred to you, and just making sure you do an adequate follow-up. Parents, the only thing they want, and they need help in that aspect, is they really want to be well taken care of. And I've been following my patients for years. I do my own follow-ups personally. I write my reports personally, and we do a lot of follow-ups at the office that are included in a package in the fee that the patient pays for this type of procedure. But as any other general dentist, I'll have some weird days where I come in at the office and it seems as though 90% of my days, that's all I'll do. I have one day I had 18 patients for tongue tie. That was the only thing. A root canal and 18 patients for tongue ties. so that's sometimes the logistics of the schedules a little bit different.
You need to schedule yourself better.
Yeah. There you go.
You need a bit more variety.
We'll work on that. Yeah, we'll work on that, because I know you do assistance in helping with adequate scheduling of a dentist practice. So we'll reach out.
The reason I say that is after I was telling my friends, I'm going to go do a GPR to figure out what I like. Maybe I want to specialize. And I did a year of GPR at the VA, and I decided I don't like anything. I mean, I like a little bit here, a little bit there, but I get bored very easily. So if you have me if I see 3-4 patients in a row, we were at the VA, so they're mostly men. But I see 3-4 older gentlemen come in at the same time, during the morning, and they all need, crown preps or something. I'm already bored, right? Half a day through, because we're doing the same thing. So, I would love to have you share your expertise and your insight in doing tongue ties. So I would invite you to start your presentation and share with our global audience.
All right. I'm so happy to do that. It's it's a really it's a great opportunity that a lot of my colleagues have asked me, but you know how we are, right? I mean, we're always busy and trying to figure out a time, and so happy we got this opportunity from last week. So let's give it a go.
Okay.
All right. Okay, so we're I'm in Canada. I'm in Quebec, actually. The only French, I could say, part of Canada, and our office is in Montreal. So the dental office is Centre Dentaire Lakeshore, and we have a subdivision because of the treatments that we do with regards to the management of tongue tie and lip tie. It's Montreal Tongue Tie Institute. So it's a collaborative space where we work with other healthcare professionals as well, because as you'll see, the only key to have success in rehabilitating babies to relearn how to breastfeed properly is through working with different professionals. So we'll touch base about that. So here's her little daughter. She just turned 7, as I said. And my wife, she's the other dentist at the office. So she will focus on orthodontics at the office, myofunctional therapy, which complements very well the type of treatment that we do for tongue tie and lip tie, especially also at later ages, young kids. So we'll develop on that a little bit as well. So the topic today, we're going to talk about demystifying the frenums, that we call it, or TOTs. So that's referred to as tethered oral tissues, because yes, they are the most common that we mostly know is the tongue tie, but we'll talk also about lip ties, cheek ties as well, because they are present as well, and they might interfere also with breastfeeding. Okay, so we'll focus on the impact at a younger age, so babies mostly. So I started my practice in 2004, so soon 17 years, and it's a little bit over 10 years ago that did more cases of tongue tie surgery. I'd say at this point, our volume at the office is around, monthly is around 40 to 50 procedures that we do. So this is a great image. I'm sure all of you can relate to this. I don't know how satisfying that could be. Don't get me wrong, I do like surgery, maybe not the ideal posture for that, but there are so many interesting things we can do in dentistry, and rewarding treatments that can be done, and definitely helping with regards to tongue ties, lip ties is something that I've really come upon. Unfortunately, during our dental school, we did not have much training in that topic. So a lot of it you have to develop by yourself. You have to go to training, see classes. But there are great organizations that are present, that give conferences once in a while, and so many resources for you to help start treating those cases. So this is an experience that some might relate. Sometimes for the first baby, you're, as a mom, you imagine your baby coming, giving birth, and probably imagine that that's the best experience, or at least, people have shared with you that that's the best thing that could ever happen, is giving birth. So you anticipate that moment, but, baby is born, and then baby's put against you, it's hot, baby's snuggling against you. And baby searches the breast. And what happens when baby is on the breast, suddenly, imagine this, starts to hurt a little bit. And then, you feel that. And it hurts a little bit more. And you wonder what's going on. And as the days go by, it can be more and more of an issue, more and more problematic. You get more issues with, infection, mastitis, blocked ducts. And you're wondering, well, this is getting into a nightmare. So what's going on? You may even get depressed from that. Baby cries all the time, has a hard time sleeping. So those are just a couple of symptoms that could arise from not being able to have an efficient feed, and having that structure that would interfere with proper breastfeeding. But in between healthcare professionals, like us, there's some confusion sometimes that arise from that. There's no strict consensus. We work in close collaboration with some professionals, but the standards do not seem to be the same at the same level, and so a lot of it has to do with with education. Training. Like I said. It's not a popular subject, unfortunately. And, sometimes what happens, you just go home, mom goes home with babies and you're left with no resources, trying to figure out what happened. And it's so fortunate that we are able to help. And, one of the goals of this presentation is just to bring awareness as well, that we can definitely play a key role in all of this. Here in Montreal, we have one hospital who's amazing. They have a breastfeeding center. They have lactation certified IBCLC lactation consultants on sites, which is not the case for all the hospitals here in Montreal. But at the end of the day, that's really important to have a comprehensive team to manage babies when they're born. So here, there's a sagittal cut of the tongue. Sometimes parents are worried, and they always ask, I always get that question once in a while, well, if you do the surgery for the tongue for my baby, well, is my baby going to choke? His tongue is going to go back. So I guess in theory, if I go through all those muscles that you see, all those layers, possibly, but the area to really focus on is just that membrane that you see right here in the front. So just in the front of the first part of the genioglossus. So it's for tiny membranes, a couple millimeters. And the tongue has got innervation by multiple cranial nerves, as you all know. The ankyloglossia, how is it defined? Ankyloglossia, or the tongue-tied constrictor linguofrenum. It's just that tissue that's underneath the tongue, and it causes an issue with the mobility, proper mobility of the tongue, proper range of motion. And there's different ways to describe it. When I write my reports to different professionals, there are different classifications also that we will see as well. There's one that I like to use. It's a Kotlow classification, and it really helps to kind of imagine where the attachment was. So the incidence of a tongue tie, we're talking about 4 or 5% of people. Among that percentage, around 25-50% will have issues with breastfeeding. So really, it's not the majority of babies that are born that have a tongue tie that will need intervention. And that's key in being able to recognize tongue ties that need to be addressed and those that are not. Because if the idea is to release all the ties, that's all I'll do all day. Right? There won't be any discrimination, and it's very, very important to have follow-ups. And like I said, it's with different healthcare professionals as well. But most of the time, there's no incidence. There's no issue with having a tie, because we all do have, and we have multiples as well, right? It's just that little fold of tissue that we feel with the tongue. So frenectomies. Sometimes we hear that, oh, it's something new. I've never heard about it in the past. I have it once in a while. We go back in the 15th century. We read in the books that midwives have been doing the procedure back then, and they use their nails to do that. We've come obviously a long way since then, but the issue, like I said, is the consensus that is even nowadays not there between a lot of healthcare professionals, ENT, dentists, pediatricians, lactation consultants, chiropractors, osteopath. And there's different techniques that we'll go through. I choose to go with laser surgery at the office because it's a tool that I use in everyday dentistry for many other different procedures, as you know. And it's become really an essential tool in my practice, that's for sure. So with regards to the controversies that are in relation with tongue tie, lip ties, well, one of it is who to treat and at which moment. Some people, some professionals mentioned that you have to wait a certain age because of the concern of scar tissue, for instance. Wait for the canines, the upper canines to come in before doing the procedure. But with laser, the environment of work is quite different, and so that's not much of a concern in my hands. Also, I mean, we all work with evidence-based dentistry, right? And there are a lot of studies, but there could be more studies, longitudinal clinical studies. One of the things also that parents will ask me is, well, yeah, because we all have the freedom, so we'll just stretch with time, right? Thing is, freedom is an anatomical structure, right? It's not going to just disappear by itself. It's just going to be, just going to be a little bit more tension on the area, but it's still going to be there. And here you'll see like why also with controversy. So in a textbook of pediatrics in 2000, it said, right, the short lingual frenulum can be worrisome to parents, but it interferes only rarely with breastfeeding and speech, and as such does not require treatments. Obviously understand that I totally do not agree with that, and you do see it in your practice. And a few years later, American Academy of Pediatrics just revised the position and said that it's safe, it's effective to minimize with breastfeeding issues caused by asymptomatic ankylosing. So there are multiple myths surrounding that. Now, when we talk about posterior tongue tie, what is a posterior tongue tie? I mean, the tongue tie, there's different classes, and we'll see about that. But sometimes it's just more difficult to see. But with the right tool, which will show you, you'll see the posterior relatively easily. The type of anesthesia that's provided. So young babies, obviously, I will not freeze like I do regular filling on an adult patient. Throughout my 17 years of practice, standard of practice have changed. At one time, we didn't use anything. At one time, we used the regular topical that we use in our everyday practice before numbing. But there were concerns with regards to methemoglobinemia, so that was discontinued. Some people use a little bit of ice on the area to help. And at this point, we use an EMLA cream that is 2.5% lidocaine, 2.5% prilocaine, and it's sometimes used in certain salons for aesthetics. And we'll touch base also with regards to postoperative wound management. Now, that is key. The surgery itself, it's a beginning, but we really do need to take care of the wound. So we're talking about massages, and we'll go through that because that will ensure and put all the chances on our side to have optimal success for the surgery. So certain myths that we've come through and that we hear is that, well, one of it is that the upper lip's not important for breastfeeding. Well, a tie is a tie, and a tie will limit if it's severe enough, and if we evaluate that functionally it limits range of motion and mobility, then it will interfere, no matter where it is, whether it's the lip, whether it's in the cheeks. Those are sometimes overlooked, but they're very important to evaluate as well. Same thing with the tongue. I mean, the tongue is the one that most people look at, but it is important to take a look at all the other areas in the mouth as well. Another myth is that the lasers are dangerous and do not work. In my hands, that's really the best surgical tool. So, it's I've done actually one surgery with scissors, and that was back in school. So, definitely many advantages, especially nowadays. We for a regular day dentistry, it's like your iPhone. Imagine if you take your iPhone at home. The day my laser's not working at the office, it is not a good day. I literally use it every single day. And oral surgery, it goes super well with laser. I know in the hospitals, certain babies that are put in the OR for that and under general anesthesia. It's a procedure that for me, you really do not need that. I mean, if a young child will need like 3 root canals, few crowns, a couple teeth removed, and a frenectomy, yeah, okay, maybe. 4 or 3-year-old, okay, while that child is under general anesthesia, then take advantage and you can do the frenectomy if it's indicated. But just for that, not recommended. I would try mostly to do in the dental chair. Another concern that we have is that releasing the labial tie, labial frenum, will cause a gummy smile. Obviously, the lip will move more, the upper lip will move more, but the gummy smile is not linked with releasing the labial frenum. If there's a gummy smile, it's just because your orbicularis oris is more hyperactive, and that's the only reason why you would have a gummy smile. Post-op exercises are too complicated. Well, you need to manage the wound. They're not easy, that's for sure. That's why at the end of the procedure, we do have a written protocol that's given to all the patients. I show it to them how to do the exercises, and there's a video also on our website, so making sure that they really are able to understand how to do that. It's 4 times a day, and you would do it for 3 to 4 weeks. Okay, so you need to manage that quite carefully in order for healing to be the most optimal. The other one, baby will choke if I cut the lingual frenum, so we talked about that. And another myth that, well, my baby can stick out its tongue, so it's not tongue-tied. Or yes, I mean, if the tongue comes out, obviously there is more range of motion than if it does not. But when you're breastfeeding, when you're transferring milk, your tongue is not outside the mouth, right? So it needs to be able to elevate and move laterally in an adequate way. And so we'll see with regards to that. There are also some ultrasound studies that were done, fabulous studies. I think you can even catch it somewhere on YouTube, the video of that. So the frenum will just correct itself at the right place. Well, no, it's an anatomical structure. You have it, it's still going to be there. Waiting when child's older, so we talked about that. The posterior tongue tie does not exist. Well, it does. It's just a matter of having the right tool to be able to see it. Latch has no link with gastric reflux. Well, if you're unable to seal properly the breast, unable to seal the areola, you're going to have one good suck, and then you're going to suck some air. All right, so obviously that will bring some form of reflux, but there is that distinction between reflux, mechanical reflux caused by not having good seal, good latch, versus real reflux, which could happen in some cases. But In a lot of cases, unfortunately, with babies who do have reflux that are thought to be GERD, well, they just get prescribed, Prevacid, Zantac, and studies have shown that 2/3 of babies who do take those medications actually do not need. It's actually linked with a symptomatic upper labial tie. And then sleep apnea, another myth that sleep apnea is not correlated with constricted tongue ties. So people who snore have sleep apnea. Sometimes we have to evaluate with a tongue tie as well, right? Because it collapses and there's no proper freedom of movement of the tongue, and that's why there are symptoms that are related with that. So the clinical signs of a tie, you might see some indentation when baby cries, for instance. Like I said, the elevation and the way the tongue protrudes is deficient. You might see some curve of it. And the type 4, which we'll see from Dr. Kotlow, who has done so much in this field. So the classification I use is a classification of Dr. Kotlow as well, Dr. Larry Kotlow, who's a pediatric dentist out of Albany, New York. And the type 4 at the end, it's you really have to look for it, right? So when there's symptoms, you really have to be careful in the evaluation, and that's why you need a competent team to work around you. Lactation consultants, we work a lot with lactation consultants at the office, and it's really a multidisciplinary field. So aerophagia-induced reflux, so like I said, right, some symptoms can be overlapping with GERD, and so that's why sometimes it's mistaken with GERD. But it's quite a lot if we talk about babies who do take those medication. I mean, 2/3, it's a huge number of babies who don't necessarily need that type of medication. So proper tongue mechanics. So the tongue needs to be able to move and protrude, right? It needs to protrude and out in order to be able to seal during the milk transfer, during the suck, right? Sometimes we have to manipulate the areola and just position it, but the tongue needs to do that. It needs to be able to position it naturally, and when there's limitation in its range of motion, which we call, it's like a wavy motion. Well, in that case, there will be issues with mechanics, and it's going to be unable to really properly stimulate mom, and that has an effect with regards to production as well, indirectly. So if we look at breastfeeding issues, is it always caused with a tongue tie? Not necessarily, right? I mean, if we look at certain things that happen with mom, whether it's the positioning, the nipple. I mean, imagine if the nipple is more large and baby has a small mouth, right? Obviously, that won't be helpful in this situation for baby, and see certain moms who've got breast surgery, for instance, and with scar tissue, or even some form of piercing, back in the days. So, all of those could happen, and they will affect the flow. So that could be in length as well. And with the newborn, well, obviously, if you have a smaller mouth, smaller jaw, the vault is not properly positioned, with regards to other ties as well. Baby is not coordinated, so there might be some other issues to be evaluated as well. So the tie is really not the end solution for all of the issues of breastfeeding. Now, how do we determine if we do the surgery or not? Clinically, we do have to evaluate everything, all the freedoms, all the attachments in the mouth. But most importantly also, and where we take the most time, is with the history. So what's going on with mommy, type of issues, type of symptoms. We really take the time to go through all of that and what mom has been experimenting and what she observed with her child in last few days, last few weeks, that came up, the days that came up before the consultation. And from then on, we decided we do the surgery or not. But clinically, it's not right. Sometimes sure that it's standardized because they know we do the procedure. But I can tell them, well, that's just a static picture. I have to evaluate it dynamically, functionally. And so the only way to do that is through a proper physical assessment. So there's different tools to evaluate with regards to the the level of severity of a potential tie. So this is one of the tools from Dr. Hazelbaker. We also have this one, the frenectomy decision tool for the breastfeeding dyads, which was elaborated by another person in Montreal here, Carol Dobrich, who is huge in this field. She did so much, she contributed so much to this. And what's great with this tool is that it's separated in different parts. The first one is with regards to the observation of how the breastfeeding is going. Part 2 is more in relation with the tongue, how it moves, and part 3 is in relation to the upper lip. So it is considered in here as well. And then, it'll come score, and from then on, it'll determine, the possible need for the intervention. So again, some other symptoms that can be noticed with regards to baby, mother. I mean, for mom, there might be some emotional symptoms that come with that. She's exhausted. She's, depression can come from that. The lack of bond. Baby, when you look at the latch, it could be a shallower latch. Baby can click, can have gumming, biting sensation on the breast. The feeds last forever. Baby's frustrated or sleepy. There's some weight gain issues, and there's that blister that you notice that's always happening, at the end of feeds, and we're wondering why. Well, that could be linked with that. Some other problems are associated with having a tie, tongue tie, lip tie, that we see more in our practice. Sometimes cavities, having a lot of debris, tartar, can be linked with having a tie, right? I mean, what happens when you have those ties is that, there's more pooling of debris, and the automatic cleansing action of the saliva that moves around does not happen. So that's why you could possibly get more cavities associated from that. Obviously, the spacing in between two incisors. So for orthodontic reason, for speech, also. So we have a lot of speech therapists who would refer us if a tie hasn't been picked up. So usually that's around 3, 4, 5 years old. We get those referrals. Issues with swallowing. So some babies will come and breastfeeding is going great, but we do see a severe tongue tie. At a certain point, say for instance, when they start introducing solids, the issues might arise more at that point, right? And then you wonder, well, is it an issue with my baby? Just doesn't like the broccoli puree, or just because he has issues with properly swallowing and processing the food, right? So that could be interplay. Open bites, sleep apnea we talked about, and so the palate and the growth of the upper lower jaw could also come into play, like we spoke about. So some symptoms of obstructive sleep apnea for babies. Now, obviously, you will need a consultation with an ENT who do know this. But if you notice, for instance, with a baby who has a longer pause between breaths, baby who's gasping for air, is always gagging, who snores a lot, sleeps like really loudly, and some clinical symptoms that can be telltale signs. A baby who really is a mouth breather, doesn't cannot process a pacifier, or bottle, or even the breast. Well, those are things to notice and to keep track. So when we do the exam, like I said, visually it's not enough. You really need to assess it and palpate firmly to see what's going on. And I always like to be behind the child, so that's way mom can see what we see, so we can explain much better. Proper lighting, and we do have a retractor that we use, which I will show soon, and that will allow also great visibility of the area. You have to really, like I said, palpate and pull in every directions. And only then, if there's issues and there's symptoms that are present, like I said, for the decision to process the intervention or not. So it has to be in relation. Otherwise, if it's just what we see and breastfeeding going great, well, we might not do the intervention at that moment. And different ages, like we spoke about, that will have different indications. So babies, obviously, we're concerned about breastfeeding mostly. Later on, it's for speech, for orthodontic reason for infants, and later on as adults as well. We, sometimes we do see adults at the office for this, and it hasn't been picked up all their life. And all of a sudden, become an issue, and somebody did some research and told them, well, you might be beneficial to take a look at that. And so we will see adults for that. So there's different techniques. Scissors or a surgical blade. You can use also cautery. Laser is, like I said, is what we use. Now, obviously, I will obviously prefer laser over cautery. Cautery is just, it's just, there's so much collateral damage in my hands. I feel the best really surgical tool is with the laser, and so it will allow a quicker healing, also very precise, and sensitivity post-op's much better contained with laser than with cautery. And we'll go see as well different types of laser that are there. So the surgical protocol at the office. So the surgery usually is quick. Okay, it's about 20-30 seconds, and the anesthetic that we use is the EMLA cream, which I mentioned earlier. So the retractor, we'll take a look at that. The retractor is PF58 that I use cotton rolls, and my diode, my preferred laser that I use is a diode, and I use it in pulse mode, and I will explain why. And also very important when you do surgery for baby to protect the airway, so the chin up, and also my assistant has to make sure everything is stabilized to prevent from sagging on the neck. So there's a way to properly position baby, and we are helped with a swaddler that we will see. So this is the EMLA cream. This is the retractor. It looks like the Mickey Mouse ears. You can get it very, very easily from Henry Schein. I know some practitioners, they use popsicle sticks as well, but this just makes our life so much easier. So this is really the tool that I recommend. And here you can see pre-post surgery, a nice picture, a nice diamond shape, which is what we look for post-surgery, is that diamond shape. So this is my laser that I use at the office, which I love. It's light. You can easily transport it from one room to the other. And also the tips for maintenance, it's great because these are disposable tips. One of the issue when it's a long cord is that it could break sometimes, with manipulation and when things move around. So having the possibility to have disposable fiber tips is amazing from my side. So there's the board. Okay, so it could look a little bit daunting, but it's great. I mean, babies swaddle once. Usually parents come in, they swaddle their child when surgery is decided. And what we do is we will have baby on this chair converter, and we will swaddle again. As you can see, it's got 5 layers of Velcros. And so it allows for great stabilization of baby during the surgery. So it's been designed by Dr. Kotlow, like I said. And you can get it from a company called Specialized Care. So anybody who's in look for that, you can just email me at the end, and I'll let you know. I'll give you the contact for that. Safety goggles. Okay, so right there, safety goggles for everybody. It is a laser, so these are mandatory. Parents can stay in the room if we want, and they will have glasses as well, right? And with regards to sutures, well, for babies, I don't put sutures. I don't need sutures. The wound is quite small, and postoperatively, parents and babies are, they stay in a rest area, a little family room, just because after the surgery you need to calm your baby, reassure, and breastfeed to take care, and also for home care, like I said. So we do give the protocol for active wound management. There's some handouts. And with regards to follow-ups, well, I do follow-ups with all the patients postoperatively. You do want to see how they're doing. It is a very emotional appointment for a lot of parents, so you have to understand that you're giving them so much information. They might not grasp everything. They might hear you, but some don't necessarily listen to you because they have other things in their head, and that's totally normal. So it's important to follow up and to see how they're doing, if they have questions or anything like that, and follow up with your lactation consultant in a short period of time afterwards is highly recommended. Some even come to at the office, and they accompany the patient, the baby. So that's great. That's ideal in my head. And we do follow-ups at the office, at the clinic as well. So 1 week post-op and 3 weeks, so 2 follow-ups. And Bodywork is also an essential part of the treatment. So you do need Bodywork as well to help realign, and for the rehabilitation part, which starts after the surgery, and sometimes it starts even before the surgery. So this is a little idea of the room. So you just have to allocate a little space where it's more calm, and parents are out of the environmental chair, and they can just take time with their family. So this is the post-op document that we give to everybody. So when you do the massages, you can use a little bit of breast milk on your finger for the massage. You can use coconut oil as well, which has properties for sensitivity. Or you can use Oragel Baby Naturals. Parents can also give tempura to their baby. Just make sure you know the weight so that you can calculate, either you or the pharmacist can calculate the exact weight. And the results that we see are quite quick. So better latch, better suck, the milk transfer happens more effectively, there's less pain, and certain complications, which are rare because surgery is surgery, and you have to manage for that, is, well, number one, it could be partial readhesion of the tissue, but that is why you have to do the post-op care. That's why we have to do the massages carefully, take your time to do it, and at the right frequency. Infection, but that's really rare. I don't even remember when was last time I had infection. I just ask parents to be really clean, wash their hands, put gloves, and make sure their nails are filed down for comfort. It is a laser procedure, and sometimes baby succeeds in moving and jerking the head a little bit. So there could be the laser tip can go a little bit over with the other structures that are around. And in the area underneath the tongue, one of the structure that we could be concerned about, sometimes when it's really tight, is the orifice of the submandibular salivary glands. Usually it just heals uneventfully. So now we'll go through caudal calcification of ties. For tongue ties, so we'll see the pictures right here. So the ties that we see most are type 1 and type 2. So type 1 is really all the way to the tip. The type 2 is just behind that. And the type 3, they're starting to be posterior. So type 3 is posterior to the orifice of the Wharton's duct. That's the kind of the reference point. And type 4, you have to really elevate. It's posterior, but it is really limiting with regards to range of motion. It's thick, it's all the way there, but the only way, as you can see, is really through manual, manipulation. So, like I said, most healthcare professionals, they're aware of ties, they're aware of the tongue ties, but there are other ties. So how about the lip ties and the cheek ties? So we'll see about those. So the labial tie is that tissue that's just underneath the lip, right? And it will interfere with normal range of motion and function. Same thing can happen in the cheek. It's more rare that I will do surgery on that area, but they are to look out for because they could interfere. So same thing with the lip ties. So the first one is just around the area of the mucogingival junction for the type A. The type B goes all the way to the tip, right? Just at the board of the crest. And the C one, well, actually is a wraparound. It goes to the incisive papilla in the palate area. So that one's really like the thickest, the most limiting in appearance. And those that the babies who come in with severe symptoms and they do have that type of tie, changes usually happen so quick. Sometimes even the feed, as mom is at the office with baby, she feels a difference even right away. So why we choose to use laser? As most of you know, laser has many advantages, right? Cauterizes, precise, less sensitivity post-op. The need for sutures is eliminated, except for certain cases where it's more large, but that's mostly for adults that I will choose to use stitches, especially when my diamond that I liberate, after the surgery is so large, I will use resorbable stitches on that area. No scar tissue, it's a great advantage as well. And different types of laser. Well, my diode is a surgical laser. It cannot, I cannot do a film with that, even though there's some lasers who are able to. This will go through quickly. So different wavelengths of different lasers, as you know. And us, the area we're interested in, and with the diode especially, is because of the wavelength of 810 for my laser. The chromophores that we do want to target is the hemoglobin and the melanin, which is present in gingival, in soft tissue, right? So different laser interactions. One interaction that happens when the laser works is the absorption effect of it, right? So the photothermic effect of the laser will make sure that the surgery and the tissues are ablated. The fiber optic will it'll just hover like very near the surface. And the reason I like to use a pulse mode is that it allows a little bit of relaxation for the cells, for the tissue. And like I said, I like to use the disposable tips for ease of maintenance. And other than the frenectomy, there's so many other applications that can be used with the laser. Biopsies, ulcers, you can expose cavities, and especially when you do a deep class 2, gingivectomy, obviously gum surgery you can use when you remove fibroma or gingival hyperplasia. If people take certain medications, especially, and they do have that condition. I mean, a laser is really the way to go. We really need, as dentists, I believe, we really need at least a diode laser in our office. So here's a couple of applications, and it might look impressive, but it's really a clean surgery, right? I mean, people, right, immediately post-op, they see that area, and some might freak out, but it is so clean, and healing is always really nice with the laser. And these, cosmetic procedures that can be done as well. And we go through quickly from some studies, but there are studies, and I will send them to you if you send me your email with regards to many different aspects that are linked with having a tongue tie or a lip tie. But all of those studies, at the end of the day, what you will see is that it helps, okay? But we need to work in teams, and it helps quickly, but we have to consider also one part of breastfeeding, which is super important, and to rehabilitate a baby who do have a tongue tie, lip tie, is the bodywork, okay? Because as surgeons, we will liberate the tissue, but the relearning process starts afterwards. So either with a pediatric osteopath or a pediatric chiropractor, they will help in that aspect. Just realigning babies and making sure, because baby, when they come to you and baby's 3 weeks, well, that's 3 weeks that baby has compensated, and he isn't working in an optimal position, so baby needs help, in that aspect. So body workers are to be part of your team, and there's studies that show the relation, the spine, the C1, the tongue, and all of that balanced motion of the tongue is related to a balance positioning, of the spine. And so that's why sometimes baby as young as a few weeks old, they do need adjustments, right? Now, for us at the office, when you do this type of treatment, got to make sure your schedule is arranged accordingly. You don't want to have parents waiting too much, because imagine, your mother, you're in pain, you want the procedure done yesterday. So the schedule has to be arranged. The maximum waiting time is 72 hours. So I just reserve blocks that are right out of schedule in order to see baby for consultations and whatnot. And the most important thing, the take-home message of this is to work with multiple other professionals. I do write reports. We do have contacts once in a while, just talk about cases, discussing cases. But here you have a list of multiple interventions, multiple professionals who do help you. The person being the most important is your lactation consultant. So you do need certified lactation consultant to kind of oversee the whole process. Is that lactation consultant see as the quarterback of all of this. And to conclude, I'm sorry I had to cruise rapidly through the last slides, but time's been running out. But tongue tie, lip tie, can create issues with breastfeeding. Definitely issues with breastfeeding. And on top of that, could be certain consequences with that. Could be guilt from mom, so anxiety. So there are those issues that are very, very important and need to be addressed as well. Could bring to early weaning, but baby needs to be screened. It's rare that they come to you for the first evaluation, as a first line, because they don't really know. People don't really know that dentists do this, and there's not a lot of dentists who do this. I know in Montreal, we're probably about only a dozen who do this more frequently. But at the end of the day, the frenectomy is an intervention that is relatively easy, with a minimum of risk, and the rewards are immense. And for that, if it's a discipline that interests you, I highly invite you to seek the knowledge. There's multiple associations out there. There's the Academy of Breastfeeding Medicine, and there are 2 organizations which I'm part of that have plenty of resources to get you started. The ICAP, International Consortium of Ankylofrenulal Professionals, and the International Affiliation of Tongue-Tie Professionals. They have conferences once in a while. I know the ICAP does have a conference in Vancouver next fall. And so it's going to be great to mingle and hopefully in person. All right. So here I'll leave to you my information. That's my personal cell phone number. Just keep it up for you, not for the patients. And there's our email also at the office where you can reach us at for any other questions. And that's it, guys. Thank you so much.
Well, thank you so much, Doctor. That was a great presentation with a lot of insights. I do have a couple of questions from our international audience. Dr. Rebecca Mostabab asked that, do you get regrowth from gingivectomy?
So that's a great question. Sometimes you do. In my case, when I do my gingivectomy procedure, you just got to make sure that the bone is at the right level, and that will minimize the risk of regrowth. But definitely the diode that you use for this type of procedure, is a great predictable tool. So if your bone is at the right level, you won't have regrowth.
Okay. And the same doctor asked the question why you chose the diode over, another kind of laser like the YAG laser. Yeah.
So at the end of the day, you want to choose the laser that you're most comfortable with. I was trained first with a diode. I know there's a lot of my colleagues who also use a CO2 laser for this type of procedure, and it is a great surgical tool as well. I'm actually in the process of looking for that as well. But whether you use a diode, an Nd:YAG, or scissors, as a matter of fact, the important thing is technique, right? You need to know where to go, up to what depth, and you need to make sure that the tissue is freed all the way to the bases. There's some procedures I have to redo for different reasons, but also consider the fact that the post-op wound management is key. So the procedures itself is not the end result, right? You really need to take care of the wound, and you really need to follow up on the patients. Have them come back. Like for us, we have them come back twice. So plus the phone calls, and they have my number, so they can always send me information back and forth and see how it's going. But the really important thing is to keep a close eye on your patient and really work in close contact with your team, mostly with your IBCLC lactation consultant.
Do you find a lot of, let's say we're talking about babies, do you find a lot of moms sort of freak out, taking the
Of
baby
course.
home, and now you gotta manage
Yeah.
the surgery site?
Yeah, of course. So it's not an easy task. Like I said, some are very emotional when they come in. So it took me 11 years until I had the first mom who fainted. And
Okay.
since then, yeah, I didn't thought about that. And since that month of July 2015, I always make sure to ask the parents if they're comfortable being in the room. And
Right,
when they're unsure, I really escort them out. So I
right.
had two moms in that single month of July 2015 who fainted. And knock on wood, I have no other parents who have fainted. But yes, I mean, it could be daunting to do the exercises, right? It's not easy. You have to really see
Hmm.
the area, especially if it's your first child. So you have to manage. You have to manage that. And us, I mean, if we do it frequently, it's easy for us. You have perfect visibility. Your dental chair, your lighting is great. Sometimes you use
Yeah.
your loops. At home, the visibility might not be that great. One thing that a parent has used at one time, and I recommend it since then, is those camping headlights.
Okay.
So it's a great tool to have at home. Baby is
Uh-huh.
sitting on your lap, you're behind baby, and with that camping light, you can see. But at the end of the day, feeling yes, but you really need to see what you're doing.
Yeah. Well, coming from a lot of marketing training, maybe you can include that camping light in your post-op kit.
Oh, sure,
you
sure.
know
It is.
so when
Yeah,
so when
yeah,
mom go home,
yeah,
she got it right there.
yeah.
Raise your fee a little bit and
let's
put the camping light.
yeah, let's get some sponsorship with a company.
Well,
Like that.
with any of the companies that do that you work with, right?
Yeah.
You can probably ask them, hey, I want to get this for my patient, because I remember when I had my first baby. Of course, as a young mom, you're reading this book, what to expect when you're expecting, right? And I
Oh
remember,
yeah.
I still remember they say only 5% of the women would have the water break. And sure enough, that was me. And it was 2 weeks before the baby comes. So I got everything, I'm going to go shopping. I'm going to go do all this. We got the crib, but that's about it. Right. And because I was going to do everything that 2 weeks. And then when that happened, imagine you're going home and I'm telling my husband, go home and, put this in the crib and get that and get this. And so a lot of time mom goes home, and it's, especially if it's the first kid, and there's so many things going on, right? So
It's
to
overwhelming. Yeah.
yeah. So for somebody like you who choose to work with new moms, I think that's very commendable. I think takes a lot of guts. you know, the new mom always is a totally different mood sometimes, and depending on how the baby is, and obviously if the baby's not latching on well,
Yeah.
that presents a big challenge.
Like you said, it's all also about support, right?
Yeah.
The parents have to feel supported in this process. Um, some do not know all the resources that they have, especially when it's new for them, right? I mean, you just give birth, and then 48 hours you're out of the hospital already. You're kind of on your own,
Right.
unless you have some experience and you know who to turn yourself to, who to
Hmm.
consult. But a lot of it you learn directly on the field. Unfortunately, you would think that breastfeeding is intuitive, right? You want
It's a
it, and you
lot.
definitely want it to
Yeah.
be a great experience. It's just sometimes you need a little bit of assistance,
Right.
and
Right.
to be able to work in that field, it's fascinating. I work on it, and I learn so much every day working and doing this type of treatments. And I work, so it's very, very refreshing to meet other colleagues who do work around the same disciplines. Sometimes I have a parent come in and they've seen a lactation consultant. Sometimes they've seen 3 IBCLC lactation consultants. They have a pediatric osteopath who've seen them, a chiropractor who've seen them, and they have the pediatrician as well. So there's a huge team
Their team, right?
behind them. Yeah, and it's really about the team that helps. Because alone it's really like the first step for them is really for them to understand that the frenum is the frenectomy is not the end course,
Right.
and even some cases I do send them for body work before the surgery is done, just to release some of those musculoskeletal tensions. We unfortunately didn't have time to wrap up in that, but I was mindful of my time. I mean, it's all about, like I said, I mean, it's all about working with help and different professionals. And I see a couple of professionals here who came at the meeting, which is great. One of her is Annabelle. I see she's here listening, and I've been working with her for the last, I'd say, 4 or 5 years. But you really need to be in tight relation with them.
Right. Yeah, like something like Bodywork, that's new to me. I for babies, and for us in general, sometimes because we're trained as GPs to really work by ourselves, right?
Yes.
So the mindset sometimes is, oh, I got to learn all this. I need to make sure I do all this,
Yeah.
and it's great to be open minded and to know that we're part of the team. We know that we're supposed to be part of the team, but sometimes either we don't reach out, or
Well, that's the thing.
yeah,
It's we don't reach out,
yeah,
right? Because we're
yeah,
so kind of individual focused,
yes,
personalities. We go, but
right.
sometimes it's important to take a step back.
Right. So, do you get a lot of referrals for this? Is it something? How do you grow that segment of your practice?
It's really by I would say by referral and word of mouth
Mm-hmm.
at this point. Um, I wish there were more of us who do this. In where I live, and I guess around the world as well. It's a relatively newer discipline, but we're not a lot of us, and that's the thing, is that it's hard for me to always be to answer with the proper delay of wait for the patient, because this can make or break the breastfeeding totally, right? I mean, some people, they have so many issues, so many symptoms, you wish the procedure was done yesterday.
Mm-hmm.
So if there were more of us, that'll be very beneficial, very helpful. The hospitals, they do the best they can. I mean, obviously these past months have been overwhelmed with something else, but this procedure sometimes is done in the hospital as well. I mean, that's great. That's
Right.
amazing when
Right.
it's evaluated. They have a team over there. They have breastfeeding centers, which is what all hospitals should have. But a breastfeeding center with a lactation team, pediatrician, body workers. That's the goal. And I know here in Montreal we're having discussion with certain people, so we're trying to develop more on that. At the end of the day, it's really to help the families, to help the babies, but
Mm-hmm.
it's not an easy task, right? It's like changing a curriculum at a university or something, right? It takes like
Right.
so much time, and it just goes back and forth. And that's why we decided, well, it's going to take so much time. We're just going to build up something on our own. That's how we created the
Exactly.
Montreal Tongue Tie Institute, to
Right.
encompass and globe multiple other professionals who can come and work, at the office and refer each other for the cases, because the success comes from that, having everybody do their part. I like to tell the patients, so the frenectomy, I mean, if it's evaluated that it's been needed, I mean, that's just one slice of the pie. You need to
Uh-huh.
take care of the other areas as well,
Mm-hmm.
and they
Well,
need to be conscious of that.
yeah, so I think maybe somewhere along that line, to either have an OB or a pediatrician have a flyer or some kind of information. So before they go and deliver the baby, have the baby deliver, a new mom is already aware of that. because sometimes
Yeah,
the mom doesn't know. By the time you see
exactly.
the pediatrician, I don't know when you like. Usually, pediatrician, like over here in California, the pediatrician, you interview a pediatrician before you have the baby, and then when you have the baby, the pediatrician is going to show up at the hospital if he or she has privilege there and take a look at your kid and say, okay, kid look good. And then I think you probably see the pediatrician sometime a couple of days within the next week, right? And during that time, you may already have those challenges that maybe you don't know about. So
Yeah,
maybe if you were to give information to the OBs around you and the pediatrician,
yep.
that would be a plus to a new mom. Not that she doesn't have anything to do, right? Just one more thing to
Really,
be,
that's for sure.
one more thing to worry.
That's it.
Well, it's it's been such a blessing to have you here. I'm really honored to
Thank you.
host
Thank
your
you so
talk,
much.
and
It's been
thank
a
you for
pleasure. It's
sharing.
been way too short, unfortunately.
Well,
And it's funny that we took the time today. It's the only day, but it was the day I was looking forward to. It's so relaxing on this nice Sunday. I've been working, and maybe yourself as well at the office, crazy hours. The last few weeks, few months.
uh-huh.
Um,
Yes.
we do the best we can with regards to the current circumstances, but it's very humbling. Patients are coming in, and they entrust us with their care. I mean, they know it's a safe environment. We do all the protective that needs to be done,
Right.
and even during those the shutdown period. I mean, here in Montreal, we saw the emergency cases, right? So only
Right.
emergency, right? Like big infection, facial trauma, and things like that. And when we get a referral from a doctor, a pediatrician or a family doctor, well, baby can't feed. It's not gaining weight.
Hmm.
Guess what? That's an emergency. Need to see him,
Right.
right?
Right. Right. Yeah. Well, do you have any final comment, advice for in general, I think all of us as a dental team, or maybe specifically to GPs, maybe people or pediatrician, or maybe
Mm-hmm.
GPs who see a large population of from most of us don't see babies per se, but I would
Mm-hmm.
say
You could. You could start to see
certainly
babies.
certainly. No, I mean I think the youngest I've seen is maybe 6 months, where mom has this
Yeah.
concern, right? So
Yeah.
what would be your your last word advice to those of us who might want to get involved in this, or to keep an eye
Mm-hmm.
out and talk to new moms and refer?
Yeah. Well, the one conference. So, one of the organization held a conference here in Montreal. I think it was 2013 or 2014, and it was the IATB, International Affiliation of Tongue-Tied Professionals. So they do conferences every 2-3 years. The ICAP as well, and they did the conferences in Montreal, and I was the only dentist attending that conference. That was very surprising because, like I said, I mean, this is the oral cavity. Who's better to work in the oral cavity than dentists, right? So I mean, if it's a discipline that could be of interest for dentists out there, it's definitely something that's so rewarding, right? I mean, you do enjoy doing your crown prep, you do enjoy doing surgery and your implants, but when you're able to save breastfeeding, like that's at a whole other level.
Right.
And there's so many other things in the lifespan that are affected by a tie, whether that's a tongue tie
Right.
or a
Right.
lip
Hmm.
tie, right? I mean, we
Hmm.
work also in close contact with orthodontists
Right.
for the obvious reasons. There have been linked with something like snoring. A lot of
Hmm.
people know, and obstructive sleep apnea, which is so underdiagnosed and is a silent killer. So working in that discipline has opened so many doors, and at the end of the day, it's really about seeking the appropriate knowledge and seeking assistance. People who work in this field are so generous of their time. They are, they go to meetings and they'll just sit down with you and talk about cases. It's amazing. But it's really to go to those meetings, the organizations I just put up. So the two I'm
Yes.
part
Uh-huh.
of, they're great. And if you want more, I mean, really, just write to me, and I'll send you to, depending on which area you live.
Right.
There are some professionals who are more savvy in this discipline and can help you set up,
Mm-hmm.
and help your practice being set up to be able to start seeing these type of
Mm-hmm.
patients. It's much easier for patients to see us than to see their family doctor. And with regards to that aspect, we can be of so much help in whether that could be screening or doing the surgery, as a matter of fact, right?
Right. Right.
And so, yeah, I mean, it's the American Academy of Dental Sleep Medicine will have so much of information and education regarding the snoring and sleep apnea, and they will talk about this. So listen, you have my email, you have my number. So anybody who's interested to going a little bit further with that, feel free to reach out. I mean, it's really a pleasure to get in contact with the professionals.
Yeah. Well, thank you so much for your time, doctor. I hope you enjoy
Thank
the
you,
rest of
Dr.
your
Tran.
day with
Yep.
your family. The beautiful sunshine there in
I'll
Montreal.
enjoy. Yeah, you can see it in the background, right?
Yeah.
I'll enjoy a nice bike ride. Probably the last of the season here. It's 8 degrees Celsius today, so we'll do the
Oh,
best we can. Nicely wrapped.
okay. Okay. Well, thank you again, and we can certainly bring you back on, and we'll talk about more disciplines and more things that you're doing to share your expertise. So thank you,
Thank you
doctor,
very
and
much, Dr. Tran, and thank all the audience also for being here
yes,
and
yes,
taking their time on this Sunday.
yes. Thank you to all of our attendees globally, and we hope you have a great rest of your weekend. And we will see you on the next Partner.
Take care, everyone. Thank you.